And I promised you last time that I would pick on people if they didn't speak, but I was so busy facilitating the discussion, I wasn't able to keep track of who spoke. So I might still pick on folks if you don't have a chance, if you don't speak up. But hopefully everybody will find something to say. Okay, so this is our third Zoom session and related to Module 1. And part of what we're looking at today is continuation of the learning about laying a foundation regarding ASD and other neurodevelopmental disabilities. I want to follow up on some of the things we learned at the face-to-face session last week. I was very pleased with the quality of the presentations about a variety of conditions. And I imagine that all of you learned something. I certainly learned quite a bit from your presentations. So thank you very much. And before we launch into tonight, I want to know, does anyone have any questions about some of the assignments related to Module 1? Anybody have any questions? I know it's been kind of hard to figure out where to put things and what to do when. One of the things, I have had a few questions about the CDC case trainings, the autism case trainings, and a couple of folks have already completed that, and they were wondering, do I need to see the certificate of completion? No, I don't. You just need to keep track that you did it, let your mentor know. I don't need proof that you did it. If you check off that you did it and you log the hours on your tracking sheet, that's fine for me. Reason we put an relatively early deadline on that to have it done in October is in anticipation of you're heading out and doing some clinical and community work, and it'd be nice to have that as a foundation. But the due date is on the books. It's October 17. I don't need to have a certificate or something sent to me. You just keep track of it, try to get it done, and keep track of it. How many, can I get a kind of a sense of thumbs up or a wave if you've had a chance to do it? If you have, did you find it useful? Plus, minus? Okay, all right. Okay, so so much for that, and no questions on assignments. Everything's pretty clear. Okay, good. I want to talk about two new cases tonight, but before we get to that, wanted to give you a little bit of a feedback or a little bit of follow-up on the case that we spoke about last time. That was that 26-month-old with who came into the clinic with a chief complaint of wasn't talking. So when I went back to clinic last week, I got a little bit of follow-up. Our behavioral health consultant, we're very fortunate at the health department to be in the same facility. It's a federally qualified health center, and we're in the same facility as community mental health. And we have a couple of behavioral health consultants who are assigned to our clinic, and they looked into it. The little boy was engaged with early on, and in fact, I had forgotten, I spoke to the early on coordinator, the early on case manager for him last June. He is getting OT and PT and speech services in the home. It's a little bit inconsistent. Mom is having trouble keeping some of her appointments. Referral has been made to community mental health for an autism evaluation, and that's scheduled for next spring, either March or April, because of the backlog. Now, of course, ideally he would be getting that evaluation much sooner. And between our behavioral health consultant who works with CMH and the early on teacher, they were going to see if they couldn't move that up a little bit. If you'll remember in the story about him, he had not been seen for 2 years, and some of the things was a little bit confusing or worrisome that he had been lost to follow-up. And why was he lost to follow-up? And a little bit more background. We don't have great information, but his early on coordinator who goes to the home has some concerns. Her term was that she's concerned Mom might be trafficking. And when I asked, does she mean like trafficking drugs? She said, no, trafficking prostitution. So that could explain a little bit of why she's been kind of outside of our loop. So this little guy has a lot going on in his life, and you remember he's got a younger sibling. So I think it's early on plays a really key role here of connecting with the family, providing some services, and in a very non-judgmental and careful way, hopefully providing, getting them into some wraparound services. Any questions on that case? Any questions or feedback or thoughts? It's a pretty good case for all of the discussion about early signs and symptoms of autism and developmental delay, and how social factors can be intertwined with biological factors, and trying to sort all that out. Okay, well, then we will move ahead to 2 cases for today. So we'll be moving a little bit faster than last time. We did 1 case in our 90 minutes, and today we'll do 2. And some of the goals that I have with this, our learning objectives, are to talk about, for each of you to be thinking about it both from your perspective of your discipline, what you're bringing personally, and also thinking about the other disciplines working with children and families, what you can bring to each of these cases, looking at some of the conditions other than autism, neurodevelopmental conditions other than autism, looking at co-occurring conditions, how there may be more than one thing going on in an individual child, and then also thinking about the importance of the developmental context, the age of the child, and taking a life course perspective. And here, when I speak of life course, that we do think about life course as in including adulthood, but even in pediatrics, one of the things that's so much fun about working with children is the huge difference between an infant, a toddler, a preschooler, school-age child, and then when you get into teenagers, you're talking about a whole new species. So I've got couple of different ages. We're going to talk about a 12-year-old and then talk about a 17-year-old with different conditions. And these are conglomerate. The child I talked about last week was really about a particular case. These are not particular cases. These are kind of taking from different kids that I've seen and putting them together as a simulated case, or as a case. So we'll launch into the first one right now. And the first one is a 12-year-old girl. Her name is Margaret. And she is coming to the doctor's office. I'll start with the perspective of primary care pediatrician, because that's what I do. She's coming to the doctor's office for a follow-up visit to monitor medications she takes for ADHD. Margaret is, as I said, 12 years old. She is in the 7th grade. And she lives with an adoptive family. She's lived with this family for 11 plus years, almost all of her life. And she was diagnosed early based on the history, the social situation, and then some cognitive difficulties early in her life. She was diagnosed with fetal alcohol spectrum disorder. So what are we thinking about as she's coming in to be seen, kind of thinking about it before? Let's say you were shadowing me in clinic and I was busy with some other kids, and what would you be thinking as you're preparing to go in the room? What do you want to be looking for?
Kayla, go ahead.
I mean, for me in the speech pathology field, the first thing I'm thinking about is speech and language, how her language is, if she's expressing her wants and needs, if she's understanding what people are saying to her, her receptive language, her memory. I know you said she had ADHD, so her attention's not that great. Just any concerns that my discipline would cover. So that's the first thing I think of.
Okay. And from what I know you've just had an introduction to FASD. What would you expect the impact on her language, both expressive and receptive?
Delayed, for sure. Almost.
Okay. Okay. More delayed in one area than another?
I would say probably expressively, a little bit more delayed. I mean, it depends case to case. And we don't cover that to a great extent in our curriculum here at Central. So I can't comment on that a whole lot, but I would say best guess expressively for sure.
Expressively delayed. Okay. Anyone have anything they want to add to that?
Philip, go ahead.
Were there any craniofacial anomalies upon birth, such as maybe cleft lip and palate or anything else that may be pertinent to the oral cavity?
Very, very good point. No, pretty much no anatomical anomalies, no anatomical differences.
Got it. Thank you.
Jay, go ahead.
I just wanted to say that the children presenting with FASD might have some symptoms in the temporomandibular joint. May not present as a craniofacial anomalies, but the patient might have some symptoms that are causing discomfort in the jaw joint, and we will need to address, find out whether the symptoms are evident, and also if the kid has facial deformities, he might be breathing with the mouth open, and that could cause disruption in the balance of salivary flow. And so that could lead to, more caries, increased caries experience.
Okay. How about any kind of behavioral issues that might affect the health of the mouth? Maybe somebody who's dealt a lot with kids with some behavioral or executive function difference, kind of know what it's like to try to take care of your mouth.
Brandon, if you still have your comment, you can go ahead.
I don't have any comments on how to take in somebody's mouth.
Can I chime in, Dr. Turner? It's her niece.
Sure.
Go ahead.
So I would say that these kids have an oral aversion sometimes, and that can be an impediment for us to do exams, and also for them to maintain oral hygiene. And even sometimes parents, they will say that we are unable to brush their mouth because they don't want anything in their mouth. So maintaining oral hygiene at home and getting oral care in a dental setting can be difficult for these kids.
Yeah, very good point. It might be they might have oral aversion, or they might be oppositional and just not want to do it. Or at 12, you expect who takes care of the teeth of a neurotypical 12-year-old? Is their parent brushing their teeth at this point? Not usually, right? Yeah.
Brittany, if you still have your comment, go ahead.
Yeah, so what I was going to say was if she is on different like Adderall or anything like that, how is her appetites as well? So is she eating or anything like that? So that's the dietitian side of me. And wondering how her weights are, of course, how she's growing, and her behavioral too. Is she having any any outspurts of anger or anything like that?
Very good. You're right. I mean, that's one of the main things we look at when we're monitoring medications, because most of the meds that we use for ADHD do affect the appetite, usually as an appetite suppressant, and it can have significant effect on their weight gain and growth and getting the nutrition that they need. And sometimes there's a parental response that the child is not hungry and so offers more, to try to encourage them to eat. We'll offer them more, junk food. I mean, there are all sorts of things ways that can affect the nutritional health. Very good point.
Emily, go ahead.
So that's one thing I was gonna ask. So stimulants, usually you have dry mouth with that. So that would create more oral health need, but also wouldn't you check her heart, because children with FASD usually can have some heart problems, and stimulants can really affect your heart. So wouldn't that be one thing that's like the first thing you check for?
Yeah, she's been followed she doesn't have any congenital heart disease, but you're absolutely right. Part of the follow-up on children on stimulants is checking their pulse and checking their blood pressure as a routine. Very, very good point.
Ismail, go ahead.
Hello, can you hear me?
Yes.
Okay, so one major thing in school that we're looking at is the emotional state of the children. So with this child, usually with the fetal alcohol syndrome, there are going to be differences in height, weight, just facial appearance, and things like this in general. So at this age, appearance is something that's very important to middle school children, especially girls. They put a lot of emphasis on socialization, and there's a lot of stigmatism on differences, physical differences and things like this. And so if she's dealing with some type of learning disability at the same time and she's suffering in her grades, these are a lot of different things, a multitude of things that could affect her self-esteem, confidence. So you want to look at her kind of her emotional state, see if she's happy, and then these things have a role in her academic performance as well. They influence, how well she's doing in the class, if she's even putting forth an effort towards school and things like that. So that's an important thing to look at as well.
Very good point. There's lots going on at age 12, and there's lots going on both academically and physical growth and socially, and lots of social demands. What did you learn about executive function in FASD, and compare that to executive function in your neurotypical 12-year-old?
Christine, go ahead.
Well, I wasn't going to answer that question, but I was going to raise the issue about sleep stimulants, because a lot of times it impacts sleep, and that could lead to other problems if she's not getting enough sleep as well.
Very good, very good. And what were some of the things that might be influencing sleep in a 12-year-old?
Well, one, the medication might, because stimulants, and I think it's like the insomnia part of the sleep. And then just like stress or drama can keep kids up, or just not wanting to go to bed, like just wanting to watch TV all night or something like that.
Yeah. You just watch TV, or kids often have a phone in their room and they're playing with their phone until late. Or I was in clinic today, and this was a slightly older teen, or a teenager, a 15-year-old, and I asked about sleep. She's having some symptoms of feeling very weak and tired and getting dizzy. And I asked about sleep, how much sleep you get most nights, and the answer was 6 hours. What do you think about 6 hours for a 12-year-old or a 15-year-old?
Hi, this is Anne. I wanted to also just comment, I mean, that's not enough, clearly. They're supposed to get like, 9 or 10. And the kids with FASD also, they do have some sleep problems that are related to the disability. So parents complain of the kids, it's very hard for them to get to sleep and to stay asleep. And sometimes they get up in the middle of the night, that kind of stuff.
Yeah, that's a really important point, because even with the best of sleep hygiene and without medications, a lot of kids with FASD and with other neurodevelopmental problems do have trouble sleeping. Going to sleep and staying asleep is actually a pretty sophisticated function of your brain. It has to go into a kind of a different wave pattern, and a lot happens when you're asleep. So that's a really important point, that might be just intrinsic, on not because of things that are happening to her. And then there are the other things going on too, which then feeds into, how much of her ADHD is, her difficulty paying attention is because of her FASD, because she has ADHD, or because she's chronically underslept.
Hey, Jane, we have several of our trainees with their hands up.
Oh, good.
So, Sarah, go ahead.
Yes, I was going to say, regarding your question about executive functioning, I don't know if this is the right answer, but kind of teasing it out between ADHD and FAS. We know that FAS can affect their working memory, inhibition, time perception, regulation of emotions. So again, that could be tied in. But from the audiology side, we would obviously want to know, when was her last hearing test. Since she was adopted, we might not have access to her newborn hearing screenings, but either asking her or her parents or the school if there's any concerns with hearing. And again, that needs to be ruled out, because that can affect attentiveness.
Okay, yeah, okay. You have some other comments too. I'm going to let others Mike said there's some others that have comments too.
Sandy, go ahead.
In regards to executive function, these kids have trouble processing. They'll set a goal, but they have trouble figuring out how to get from point A to point B and actually putting those steps in order. So they may say, I want to go to my friend's house tonight, but they haven't thought through how they're going to get there, what might be interfering in the calendar. So executive function is, it's a key thing in just being able to process the whole thing. And I had another thought when you were talking about the whole executive function. You brought up, is it FASD? Is it her ADHD? Or is she just 12? You know, some of that behavior, because that's just 12-year-old behavior. Sometimes it's really hard to sort that out.
It can be. So this issue of getting from point A to point B and planning things out, I'm thinking about how that looks in a middle school. You know, in middle school, do you go to one classroom and you sit there all day? I mean, we're hearing about executive function, difficulty planning things. Did I hear about emotional trouble regulating emotions? And Sandy, it's a really good point. All of these are challenging for your neurotypical 12-year-old. And then when you add in the FASD, so how might this actually play out for her at school besides the academic difficulties? What might play out?
John, you're up. Go ahead.
I feel like we kind of keep raising our hand and then we go on from point to point.
Sorry, I'm sorry.
No, you're totally fine. I think people did a pretty good job with the whole executive functioning. One thing I would also add is probably impulse control. Really bad with that. With ASD patients, I had a lot of behavioral kids like that. One thing I wanted to kind of think about was REM sleep. You say they're not getting like very much sleep, but even with 6 hours, you can kind of work efficiently, but that depends on, how quickly and how much time they're spending in REM as opposed to the other, stage 1 and 2 of their sleep cycles. But
good point.
That's kind of something for the parents to know, other than putting them in through like a sleep test. Are they waking up during the middle of the night, or do they go to bed easily and stay to bed?
Yeah, it's the quality too.
Brandon, go ahead.
So coming from the school psych perspective, going to the room, I'm gonna be wondering about her level of her cognitive ability, struggling with learning disorders. Of course, people in executive function cover the planning, initiating tasks, processing ability, working memory. So it's going to be in middle school. It's like, okay, am I remembering to bring my materials to class? How many times does she have to repeat things in order to learn certain concepts? Of course, social cues. Is she picking up on social cues? Other things like coordination, psychomotor ability, how's she developing along her neurotypical peers, things like that.
Excellent. So it's pretty broad, isn't it?
Yeah.
Yeah. And is there somebody waiting to say, Mike?
Yeah, we have a couple. Madison, go ahead.
Sorry, I'm not letting you guys see my face. I'm eating, so I didn't want you guys to see that. But anywho, from an audiological standpoint, I think it's also important to consider, she said she has ADHD, and a lot of times we see kids come in for auditory processing tests. So essentially, a child with auditory processing cannot process from the sound going to the ear up to the brain, and therefore they can't make sense of the information or the input that they're receiving. So I know specifically in our auditory processing class, you had to differentiate between whether or not sometimes kids with ADHD can present themselves with auditory processing, but when in fact it's just the auditory processing. So that's another thing to consider for an audiological standpoint. And then also that these kids can also have hearing loss. I was curious to look up more about it because we really didn't touch on it at Central, but that you can have hearing loss in those children with the fetal alcohol syndrome. And it can range from either a conductive part of hearing loss, what we call, so that's something more medical that you can kind of fix with time, or it can be a more permanent hearing loss. So
lots to consider. Yeah.
Peggy, go ahead.
Can you hear me?
Yep, we can hear you.
Okay, I was just going to tag on to what Brandon was commenting about, but I was also thinking about like peer relationships, extracurricular activities, things around home, and involvement and staying on task with that. Just to expand all these great ideas.
Okay. Let's shift a little bit on this from, we've been identifying a lot of the challenges for Margaret. And we've been talking about the medical and the educational, the psychological, the dental. Let's construct a care map. Let's think about what are the different services and what's important in Margaret's life. So if you've got a piece of paper, jot down some of the things. Margaret goes in the middle and then her family, right? And her family. And there's medical and dental and hearing. And then there's school. So can you see any of that? Medical, dental, school. What about all the rest of the things for her? That might be both just what 12-year-old girls do and what might be of particular value for Margaret. What about friends?
Sandy, go ahead.
That's just what I was going to say. Friends at that age are really a crucial being.
Could you say that again, Sandy? I couldn't hear that too well.
Oh, just what you said. Friends. At the 12-year-old level, they're just starting to make those middle school, possible lifelong friends. So those are crucial.
Yeah. So the things we've talked about could kind of interfere with that, right? Some of the executive function, being impulsive, if she's having auditory processing problems, misunderstanding her friends. Yeah. How might what might be able to do for that or about that? Any thoughts? Sandy, have you found anything for kids with special needs to help them form those friendships?
Oh, well, working with the parents to community events are big, for kids that have a little bit of a difference. I know just even in our town, we have a thing called Top Soccer, and it's for kids who can't play typical soccer. And we were actually at the pediatrician's office today with the nurse practitioner who didn't know about the program. He said, I have an 8-year-old who plays soccer with my son, but he's autistic and he can't follow the rules. He won't get off the bleachers. But she didn't know of this program. It's for kids that are cognitively delayed, physically delayed. So, just getting the parents involved in activities like that. 12-year-old, it would be, invite a friend over, one friend, start with one friend and see if you can build from there.
Yeah.
Brandon, go ahead.
Sometimes social skills groups work for these individuals, as well as training them with a social skill group to help them become more aware or try to help them have some type of awareness around some of the behaviors that might prevent them from developing some friendships, and then train them like a more social older student in their school to model some of those positive behaviors to them as well.
This is Anne, and that's a good point, Brandon, because one of the programs, there's about 5 that have been found to be evidence-based, and there's a social skills program for these kids with FASDs that works very well. And And that you might be, I think there's a link to that under resources on the Blackboard. I put an FASD resources list, so you can go there to look at it.
Kayla, go ahead.
So I was going to say something similar to what Brandon said. When I was in high school, there was a boy with autism, and he really struggled to make friends, just to develop any relationships. So the school counselor reached out to just people she knew would be willing to kind of develop a relationship with him. And they started having like twice a week lunch groups just to kind of hang out for him to maintain those relationships and friendships. So that was a really cool experience because most of these kids ended up staying friends with this boy with autism. And it was great for him to be included with his neurotypical peers, which, you know, inclusion is awesome for these individuals.
Philip, go ahead.
Yeah, perhaps the parents could also inquire that the school provide resources. I was just looking online. There's a Michigan Coalition for Fetal Alcohol Resources, Education, and Support. So that gives the school resources to help children be academically successful. And so I think that would be a pretty neat thing to inquire about on the parents' behalf.
Besides school related, what about other things in the community that might be helpful? There's what Ann mentioned, and Michelle you sent us something about a links program. Other thoughts of resources in the community?
Michelle, go ahead.
Okay, well, I was just going to comment on the links program, but I can answer your question too. I was just thinking, even if you went through the links program and hooked up with some maybe positive peer role models, maybe that could correlate into like a dance class or just getting together. I think it was, I'm not sure, somebody mentioned about just having them over to their house, or like meeting up at the movies, or you know, going to the Apple store. I mean, there's a lot of things of just kind of building friendships, and I feel like that could go through this links program, or it could go through your school social worker to kind of maybe foster a relationship when it's hard to make friends on your own.
So there's, just so you're aware too, there's McFairs, which I think the previous speaker mentioned. I can't remember who that was, but that is actually a family run. It's run by a mom of a couple of they're young men now with FASD, and she's considered also the national, or our local NOFAS, which is NOFAS is the National Organization on Fetal Alcohol Syndrome. So she does that. Her name is Charisse Kosu Kowalski. And we work together on the FASD task force, which I wanted to mention. I'm going to send you all an invite to. It could count towards community hours. We'll be meeting in November, and you can come in person or join us by phone. But I think it would be really interesting for you to hear what some of the parents and professionals who work in this field are talking about and what's going on. So it turns out, FASD is not something that the schools recognize as a distinct disorder. The kids usually come under OHI, or emotional impairment. So we're really struggling because the problem with the facial features affect about 15% of people and kids, and really the neurobehavioral and developmental disorder pieces are what really gets folks, in trouble, and they have difficulty in school and with their behavior and social skills and all that. So part of what the task force does is education around that. But Charisse's group has family gatherings, and there's online support. And there's two Facebook sites. One's called MIFASD, and the other one is McFairs, and they offer parents a place to go and talk about, issues concerning their kids, and how to find resources for them. And sometimes they do organize some social activities for the kids to get together and stuff too, and the families.
Yeah, thanks. And well, as well as the schools not recognizing, I'm sure that we as physicians often don't recognize it. And FASD is so much more common than we like to believe. I have a hunch that a number of the kids that I have followed over the years with ADHD that doesn't respond well, the medicines help a little bit, but don't really control the symptoms. I have a hunch a number of them, and they're kind of oppositional, and they make bad choices and get themselves into trouble making bad choices. I bet quite a few of them have fetal alcohol effects that have been unrecognized.
Yeah, there's a lot of stigma. I think that's one of the reasons. So, and physicians are hesitant to ask about it. And we still have physicians saying it's okay to drink when you're pregnant a little bit. And what a little bit means is, of course, up to each person.
Yeah.
So there's a whole lot of ways that we kind of don't deal with it. And alcohol is such a big part of this culture, and the whole idea of, individual rights and alcohol. And, there's just a lot of ways that we just kind of don't deal with it. And really the most recent research is saying that the rate of FASDs is much higher than the rate of autism spectrum disorders.
Yes. Yeah. Yeah.
But we're not, there's so much stigma. And, when I talk about this, women don't purposely drink to harm their babies. There's a whole bunch of reasons. People don't know they're pregnant. People don't know that drinking causes problems. People have substance abuse issues. They're in a violent relationship where they're kind of forced to drink with their partner or risk being beaten. There's all kinds of things that happen. So I always say no shame, no blame, just trying to figure out how to support women to at least decrease or stop drinking while they're pregnant.
No shame, no blame is also, I think, with the kids often because of their poor choices, they get blamed, or because they look like they should be learning and they're not.
Right.
Or they learn something today and it's gone tomorrow, puts the kids often in a position of being blamed, not for the alcohol, but for their behaviors.
Yes, exactly. Yep. Yeah, we see that too. And so, yeah.
Jane, we have a couple hands up. Katie, go ahead.
Yeah, the first thing that came to mind when you said what other kids are involved in at that age was Girl Scouts. So I know it might be a little bit kind of late in the game to get involved in that, as far as, you kind of start younger in the DAISY program, but that's always an option that might be possible to get her socialized, and also doing volunteer work and having some kind of drive to do something.
Very good. Yes, use something like Girl Scouts or volunteer. And Katie, I like the visual. Look over your left shoulder. Keep calm and drink wine.
Yep.
Yeah.
Ismail, go ahead.
Hello?
Yes.
So one of the things that I think is good is just sitting with the child and trying to find out who the child is and what they like and what they enjoy doing. So every child likes something, whether it's art, whether it's sports, whether it's music, whether it's going to church. If their parents are very involved in church, it could be books or anything like this. And then using that activity, so you have to find out what the child likes, and then use that activity as the base for their social circle and as the base for them to gain those social skills. And sometimes you get kids that are, they're kind of nonchalant, and they're like, well, you ask them what they like, and they're kind of like, I don't like anything, and nothing interests them. And so for those kids, it's good to perhaps do a personality assessment, see what their skills are and what their strengths are, and do kind of like exploratories and just expose them to different things systematically, and maybe they'll find something in a music class that they take or something like that that they end up liking. And so once you engage them with that activity, then you can use that as the base to help build the social skills. And you can teach them social skills the same as you teach them math or you teach them English. You can give homework assignments around that. They could have for a particular week, make a friend this week, invite someone to the movies, invite someone to your house, throw a party, and then you can talk about what does that entail, throwing a party and these types of things. And so the special education teacher especially can give them assignments based on these activities. And the draw is this is something that they're like or something that they're already interested in. And so that's going to be the motivation for them. And that's going to be the common network with the friends in that circle to help build those skills.
Thank you. Yeah. Well, unless someone has a burning comment about this particular case, I want to move on to a case of a 17-year-old. Is that all right? Does someone have something that they just haven't had a chance to say? I don't want to cut folks off. Okay, well, the next case is also a case of someone with co-occurring conditions. And this is about a 17-year-old man named Alex who has Fragile X. And as his components are occurring with his Fragile X, he has autism, he is on the spectrum, and he has epilepsy. And he is 17, so I really want to be thinking about his circle of life, education, vocational, social, community. Let's think about, the impact on his academics, and then what do we need to be thinking about for the future for Alex? So part of why I wanted to bring up Alex is to talk about the co-occurring conditions and balancing those, and also be thinking about transition, and with transition here, thinking about transition to adult providers, educational transition from the educational environment to vocational. Is there a transition, from where residence? Is he going to be moving out of his parents' home? A neurotypical man at age 17 might be thinking of moving out of his home. So what do you think about with Fragile X and autism and epilepsy? And I think you've all had a little bit of background on those conditions. Any thoughts?
John, go ahead.
Do you know the patient's IQ? Like, are they relatively normal functioning, or do they have IDD?
His IQ is in the upper 70s.
Okay.
By the way, in the standard measurements. That doesn't tell you all of his function. That would be by standard measurements.
Do you feel like he's able to live on his own independently?
Well, I think that's a good question. Yeah, what would be some of the indicators that he might be able to live on his own?
Being able to clean, take care of himself, bathe himself, cook, methods of transportation. Is he, able to drive, or can he learn how to take public transportation?
Yeah, I would say for Alex at this point, he doesn't have those skills. He's able to bathe himself and dress himself and feed himself. He's not good at meal planning, doesn't really know how to shop, and hasn't learned how to ride the bus at this point. But you know what? How many neurotypical 17-year-olds have all those skills down?
Emily, go ahead.
I was just going to ask, does he qualify for educational services until 26?
He does.
Okay.
He does. Unless he graduates. Do you know that issue?
Somewhat. I think that some other people would be better equipped to explain it than I would.
Does anybody kind of know that regarding education and what the options are?
It's something to do with if you get the diploma, correct?
Yeah, if you get the diploma, you're done.
Okay.
And I know some families, that's a bit of a dilemma, or they don't really think it through before they're so happy that their child can graduate from high school, and then it's like, oh, it's all over.
Well, education is over, so if they don't graduate, they still might be eligible for services up to age 26. In Michigan, we provide these classroom experiences, which, to tell you the truth, I have mixed feelings about, because they end up being in a classroom till they're 26 and not really doing kind of real world stuff.
Mm-hmm.
Getting out, having a job, it's supposed to give them those experiences, but that doesn't seem to lead to real jobs very much. So the option is you either graduate and then you go into the community mental health system, where there's adult services, and they're supposed to offer employment services and community living supports and all those nice things. Or you stay in the education system. The issue is for families is that it's a big step to kind of leave education up to the point that your child graduates, providing really pretty much all the services. And it's a big shift into kind of community mental health and developmental disability services. So it is a big step to do it. So there's, the ARC and the local ARCs and the Michigan Alliance for Family are good folks to know about too, who can help families try to figure out what they want to do next.
Brandon, go ahead.
All right, so I had questions regarding daily living skills and his baseline level of functioning. But in following what Ann said, you know, for an individual like what's his name?
Alex.
For Alex, I used to work for a program, or one of the programs under my watch was something called Project. And what we do is we link individuals with different disabilities with different organizations like the hospital or banks who are willing to take these individuals and build a plan regarding assisted living, or, you know, whether they needed assisted living, complete care, and then, you know, getting them familiar with a bus route to take them to, you know, a job. And these jobs are paying, you know, between $20 an hour, relatively good paying jobs once they were able to develop or master the specific skill set. So I'd really have been interested in his, you know, what he could do. But those are the things I'd be looking at in order to get him a good placement and start developing a plan for postgraduate or post certificate.
Very good point. Yeah. Are any of you familiar with Project Search? You're able to see Michelle's comment to you, Brandon, about sending the name? Yeah.
It was Project Search. I'm not sure. Now this was a few years ago in Grand Rapids. I'm not sure if the program is still up and running because I have since left that area. So I'm not sure what the state of that program is.
The National Project Search. And Ann, you may know more about it, or do we have any of the mentors on that are familiar with it? We have a couple of mentors at MSU who have been working on it. It's a project. It's for a post-high school internship for individuals with developmental disabilities, with some intensive skills training and an internship. It's an unpaid internship, but it often leads to employment. MSU has 10 interns. Last year was their first year. They have 10 again this year. And the state of Michigan has launched the Project Search with similarly 10 interns. Small numbers, effective programs, unfortunately small numbers because there are many other individuals that could certainly benefit from it.
Sandy, go ahead.
That sounds like a great program. I am going to look that up. But as far as Alex goes, one of the things I would be asking the providers is, at what age do you transition your pediatric kids to adult providers? There are some pediatric specialists who carry their kids beyond age 18. So that would be an important thing to know. How much time do they have and things like that. And then is he going to need somebody to take over as a guardian? If he is able to live out in the community, is he still going to need somebody to oversee his financial needs? So those are all things to look at. Hopefully they've looked at them long before age 17, but at 17 they're still important.
Yeah, what age should one start talking about these things?
I know with children's special health care, when we go out to the homes, we usually start at age 14, depending on the age of the child and what's going on with them. Sometimes it's almost 12. So we try to do a pretty good assessment of what, with the family and the child, what they think their needs will be at 18 and then at 21 when they age off of the program.
Yeah, and it's recommended for physicians to start talking about it, and I think the schools with IEPs start in the early teens also, starting to have that conversation. Regarding your comment about someone helping him make decisions, Anne, do you have anything you wanted to add on that?
Oops, sorry. You know, we're going to have a session on supported decision making and alternatives to guardianship coming up in the spring. So there's lots of options. Guardianship is really, although the schools recommend it a lot, it's really a last resort, and you know, because it basically takes away a person's rights to do pretty much everything that's in the guardianship. So we'll be talking a lot about that and looking at some other ways. There's a thing called supported decision making, where people around the person help them make good decisions, and you don't have to take the person's rights away. People often think guardianship is kind of like the answer to, all this person will be protected, and we won't have to worry, but that's not the case. Bad things happen to people who have guardianship too, and really what we need to be thinking about is how do we build a circle of support around them. So yeah, I'll be talking about that. I think it's in the spring or early winter or late winter.
Yeah, thanks. And I know that's coming, but I think it's important that we lay the foundation and recognize that it's not just, you're out there all on your own or someone is making all your decisions for you. It's there are ways of providing support without taking over, all of a person's rights to make decisions.
Hey, Jane, we have several trainees with comments.
Good.
Ricky posted in the chat that he's having computer issues, but he did say that he works with Project Search now, and it is effective for vocational aspects. However, when it comes into regard for functional independence, such as cooking and living on their own, it doesn't touch upon those skills, which is the difficult part. And he also says that transition planning should start occurring at around age 14. I believe, Katie, you're next. Go ahead.
Yeah, piggybacking off of that and off of John's comment, that's where I come in. That's where the OTs work on those aspects of living. He's got some of the ADLs down, which some he might still need to work on, but the IADLs, things such as driving and grocery shopping and those functional independence things, paying bills, stuff like that. If he gets to have time one-on-one with an OT to work specifically on those things, he can gain independence in those areas.
How about romantic relationships? Is that going to be an issue for Alex? Or sexual behaviors? He's 17.
Christine, you were up next. Did you want to
I mean, we can hear you.
Yeah.
You don't have to respond to that, Christine. You can go ahead and make your other comment. I just wanted to throw that out there.
Okay, so from the medical standpoint, I was going to ask, what type of seizures he has and if they are, managed with medication. So would he be able to live alone in regards to that, or does he need someone there to make sure he takes his medication, to make sure he's safe? And then another question I had was about the transition from a pediatrician onward. I might be wrong, but isn't that what Med Peds is for? Is that so that they can take care of both, so that they can translate, or is that not?
That can. There aren't enough Med Peds to take care of all, and many Med Peds doctors, people that do Med Peds is those are individuals who do a residency. It's a 4-year residency that they become board eligible in pediatrics and in internal medicine. And in pediatrics alone is 3 years, internal medicine alone is 3 years. So Med Peds, they're kind of a fast course to having it across the lifespan. They typically the residencies are more specialty focused and more hospital focused, and a lot of Med Peds doctors go into fields that they do further specialization into a field that covers both. But a Med Peds doctor, if you can find one who can be a primary care doctor, that's terrific. The other is often family docs. Family docs often don't take care of your more complex kids as kids, but our experience with many of our patients is that our family physicians are ready and willing to take on many of our complex kids with developmental disabilities and are a little more comfortable with developmental disabilities than some internists. But that's a very good point. How do you make that bridge? Because it's a very different model of care. Pediatricians, we tend to do a lot of hand-holding and a lot of nurturing and responding to questions, and adult doctors are used to, it's your body, it's your responsibility, you call me when you need me, but I'm not going to be tracking you down. And that's it's quite a bit of a shift. Then regarding the kinds of seizures, excellent points. How much are his medical conditions going to influence his independence?
Peggy, if you still had a comment or question, you can go ahead.
No, that's okay. I put my hand down.
Okay. Philip, go ahead.
Yeah, so as a comment with the seizures, because Alex also is on the spectrum, if his oral health isn't doing so well and he does need extractions for a lot of his teeth, it's potential that he has dental prostheses. Now, his independence of living alone could be hindered with his seizures because it's also a choking hazard if he's frequently having seizures and he's having dentures in his mouth. So that's another thing that we need to take into account with his independence. So
very good point. Yeah. And my experience is that many children and youth with Fragile X and on the spectrum have their dental care has been one of their lowest priorities. And partly because it's just so hard to get there. And the other is that they may not be able to sit in the dentist chair and cooperate, and so they have to go under anesthesia to get things done. And how often do you want to put a child under anesthesia? So dental is frequently neglected, not because people don't know that it's important, but it's just when there are all these other things going on. So Ricky, Mike, do you want to read from Ricky?
Sure. Yes, Ricky says, yes, it should. A sex therapist actually should work with Alex and his family if they are willing. It is researched that individuals with disabilities who do not get extensive sexual health training actually not only get taken advantage of, or rather may get taken advantage of, but also commit the acts of possible sexual assault because they are unaware of the educational piece behind it. It's seen as taboo for many professions and families to touch upon sexual activity for individuals with autism. So that's a price that is essential to address, a piece rather, that is essential to address. And in the US, and Ricky says, correct me if I'm wrong, many individuals with disabilities in the school system are able to opt out of sexual health education in their education, which then plays a role in this lack of education and then possible problems that may arise in the future. Hopefully this makes sense. I'm sorry my phone isn't working. It does to me. It makes sense.
It makes a lot of sense. And thank you, Ricky, because everybody else was kind of silent when I brought that up. Makes us uncomfortable to talk about sex, and particularly talk about sex for someone with developmental disabilities. This is one of the things that can be really hard for parents to deal with, and kids with challenges in social communication and social interaction can frequently misunderstand the social cues from others and get themselves into trouble. They can be taken advantage of, or they can get into trouble for behaving inappropriately. Just how to touch people and how much to touch people. You can imagine, how you just, they're very nuanced. It's, and then beyond just how to touch people, the really learning about sex. And it's not just, going to just a one class on, the kind of class that you get in 5th grade and 7th grade is not sufficient for an individual that needs to have repetition. So I don't know if anyone else has anything to add on this, or those that are, family members have anything. It might be a little too personal, but to give us any insights on good ways to manage this very important aspect of life.
Ismail, go ahead.
I was going to say social groups, especially at that age. There are communities out there for people that have autism, and a lot of times people find partners in these communities, the social communities they can participate in. They can get together. Sometimes it's online. And sometimes when you talking to someone that has a similar disability or something of this nature, the people can relate more, and you can find someone that you can kind of bond with and kind of interact on a level that you're comfortable with. Another point was role play. Role play is good for these students, just to go through what they would do in in a hypothetical situation, go through different scenarios like rejection or intimacy, talk about things that are important. Eye contact is difficult for people on the spectrum, so try to encourage them to do that. Try to encourage them to understand the different social cues that the opposite sex might be giving off, so they can process that information and then react accordingly.
Sandy, go ahead.
I just have a situation that came up. Part of my job at the health department is to do community events. So every year when Northwood University has their welcome freshmen, they bring in a lot of community agencies, restaurants, etc. Just because a lot of the students come from out of state, just so that they know what's available in their community. So I go as a health department representative and I take a bowl of condoms. And one of the programs that our health department has, there's 2 in Michigan that have a program called Take Cover. And it's a bag of condoms, and there's a little barcode on the card you get that tells you what places in the community actually have these condoms free, bars, restaurants, coffee houses, et cetera, et cetera. So I had a young man come up to the table who was obviously developmentally delayed. And he came up and he said, "Oh, what's this all about?" He looked to be of age. It's a college campus, so I was explaining it to him. And his mentor came over, who was a gentleman probably in his 60s. And he said, "So what's this?" And I said, "Oh, I'm explaining the Take Cover, the condom program to him." And he says to the guy, he says, "Oh, you don't need this. Here, this is more your style." And he reached for a sucker on the table beside me. And I thought, that was such a perfect opportunity for him to do a little education with this young man. I felt bad for him. But there wasn't anything I could do except to say thank you and wait for them to go on. But I felt like, that was just such a great opportunity for him to work with that young man.
Yeah, thanks for that.
Emily, go ahead.
Just kind of going off of what Ishmael said about, I work with a lot of undergraduate male students with ASD. And one thing that I've noticed a lot is fixations on when talking about like partners, and sometimes they get like fixated on girls, and that's something that should be, I guess, like talked to and addressed, and also dealing with rejection.
Yeah, there can be some issues where it's interpreted as stalking.
Yep.
Yeah. Okay. So we've talked a little bit about the social and the medical transition, the things to consider regarding independent living. He's only 17, and they're probably not making a move now, but the family's probably thinking down the line, the future. We'll talk more about way of supporting decisions in the future. Dental care, auditory. So let's think about for Alex, the old care plan idea. We've got the medical. I always put the medical on first because I'm a medical, right? It's got the medical and the dental. We talked a little bit about the social. We kind of not quite sure. What was the Netflix? What was that documentary? I couldn't see that on my screen completely. Somebody's sending information.
The one I posted was Autism in Love. I haven't watched it in a couple of years, but it was about relationships and kind of navigating the dating world as a person with autism.
Okay, thank you. So important because, we sometimes we make the assumption that because someone has autism, they don't want friends or they don't care. They don't want those social relationships. Okay. So what would be some of the next steps with Alex? There's a lot of unknowns here. He's got some cognitive impairments. He's pretty good at most of his activities of daily living, but not taking care of his cooking, medications. He needs some help, transportation. We talked about making the medical transition. Let's talk a little bit more about other community supports. We learned a little bit about Project Search, which is available to a few people, not enough, but Ricky, you're going to help expand it, right? It's going to go broader. Other community supports. What all does community mental health have to offer? How about DDI? Maybe we have to pull on Anne here. She's an expert on all of this.
I just got back. What was the question?
Other supports, community mental health. What does community mental health have to offer for, I'm sorry, putting you on the spot all the time here. I can't tell when you're at your computer because we're just seeing out the window.
Yeah. There's, excuse me, community mental health offers services for kids and for adults who have intellectual and developmental disabilities. There are more services as you become an adult, and we talked about some of them, community living supports, which would actually come to your home and help you, with learning how to do different things, like cooking, doing your laundry, or if you need more help than that. I know a woman who lives in her own apartment that she's not able to maneuver without using her wheelchair, so she has to have help to get in and out of bed, to get to toilet, all of that. But she lives in her own apartment with supports that are provided through community mental health. So it's not impossible. It's quite possible to develop the support you need as a person. There's using person-centered planning, which has kind of a different meaning in terms of adult DD services than when we talk about patient-centered care and that kind of thing.
So what does person-centered planning mean?
So it's really looking at, the person as the focus and what they want, and that the people around that person who they want in their life are there to help figure out how to get what they want and get there, and not do it as, everyone just gets the same set of services. It's really very individualized. So I have another guy I know who he has a severe intellectual end. He also uses a wheelchair, and he doesn't speak verbally, but he lives in an apartment with a friend, and the people who've known him over the years know what he likes, and he likes, he likes to go out. He likes music. They figured, what he likes. He doesn't like a lot of noise in his background. So they kind of have built a life around, even though he's not able to communicate in a typical fashion. They do know what he likes, and they've built a life for him around that. So there's just it's a very different way of thinking about it, other than everyone gets kind of slotted into a bedroom at a group home where everyone's kind of treated the same. You get up when everybody gets up, you have to eat when everyone eats. So there's a lot of thinking, changing and thinking about how people should be directing really their own lives, and not just people who can tell us what that would mean, but other people who show us what that means.
So Anne, is this aspirational or is it actually happening?
So it's both. It's happening for some people who have good advocates, basically, whose families advocate for them or have other people in their lives who advocate. But the system is being forced to go this direction by the changes in the Medicaid rules and the changes that are happening with the home and community-based waiver system, which Michigan has been in for a long time. And now there's more push through the Centers for Medicaid and Medicare that this is what people should get. This is the kind of services they should get, very, very centered on their needs and wants and goals. So we're in a process of another kind of, I think, period of change, how that works. But of course, individual CMHs deal with this stuff differently as much as they can. They're supposed to follow kind of, the general rules. So I think they're going to be pushed to do more of this, though, with the changes coming from the federal level.
Okay.
Excuse me.
Yeah. Well, and everybody across the all the LEND networks across the country who are learning about this can help to promote the person-centered planning. I mean, whether you're
you guys are the new generation that's going to help make this happen.
Right. Take it for granted, and not just saying that this is the way that things need to be done. And you're absolutely right. It's a very different framework than patient-centered medical home. The patient-centered medical home is really medical home centered and not patient-centered.
Mm-hmm.
A misnomer.
Yeah. So we'll be doing more talking about person-centered planning too, I think, as over the 2 semesters, and having some people come in to talk about some different aspects or just show it. I mean, Abby was a great example of person-centered planning. Her family and Abby have been doing that for years, and even at school insisted she was included, and you can see the result of her being included. She's just phenomenal what she's does and how she feels about herself. I mean, you can just tell it in her presence. So that's why, you know, we have other people who are going to come in and talk about what that looks like for them too.
Yeah.
Emily has a comment.
I actually had a question for Anne. So do individuals need an independent facilitator to go through the person-centered planning process?
I think that's ideal. And so now also the system is really pushing that. And what independent facilitators would be is that it's not your case manager who works for the agency that's going to give you the services or help support you, which can be a conflict of interest. So the newest thinking is you have people who are independent of the community mental health system who help facilitate a person-centered planning meeting so that there isn't any pressure in terms of, you know, the case manager feeling like they have to kind of, you know, toe the company line or whatever. So, and then it's a cleaner process. And I've seen it happen with independent facilitators, and it's just a much different feel to it because the independent facilitator doesn't have to worry about that. And so it's very much, you know, what's this person's dreams? You know, they start talking about dreams before anything else. Just like you and I, you know, we wanted to think about what do we dream about our life? Not just that we need a house and we need food, but we want to dream other things too. So I think that's, again, something that looks like it's going to start getting pushed more and more is to have independent facilitators.
Other comments? It's quite a bit to think about. Thanks, Anne. Thanks a lot.
There are no hands up right now.
Okay. So as we think about Alex, it would be great if he had an independent facilitator as well as his parents and people in the schools that have worked with him and those in community mental health. And there may be others in his life when we think about all the, you know, other community organizations, neighbors. Sometimes it's formal and sometimes it's informal. And with Alex, his epilepsy and the severity of that and how well it's controlled can certainly make a difference. And that may not be something that's steady. A lot of individuals who have epilepsy may be well controlled for a while and then something changes and we don't really know why and they start to have seizures again and has to come under control again. Did anyone not have a chance to contribute this evening? I think we've heard from everyone, haven't we? How about any of the mentors? Did anyone have something they would like to add? I know we've asked mentors to stay in the background, except that I kind of clued Anne in on the topics tonight, which are topics in which she has a lot of expertise, and I asked her to be an active participant. But how about other mentors?
This is Harneet.
Hi, this is Jenny. Jane and the trainees, a wonderful job. It was very interesting to hear just about everybody who contributed from a different perspective, and it made the case a lot richer than just hearing from the presenter. So thank you.
Thank you, Jenny. Yeah, good comments from the group. Anyone else?
So this is Janie. I just wanted to say that I'm curious about getting payment for services with some of the things that you're talking about, because I think that's one of our struggles when we work with patients and families is how to get things paid for.
So what happens is people become, if you're found to be developmentally disabled as an adult you usually can get Medicaid. So the process is to apply for Social Security benefits. And if you get SSI, which is usually the first step in Social Security benefits for young people, then Medicaid automatically comes with it, and that pays for community mental health supports. So that's how that works. And then, so often that's at age 18. Some people have SSI as a child, but they have to reapply as an adult at age 18, and they can do that a few months beforehand. It's unfortunately the system it's pretty bogged down right now. and also there's a lot of high rate of refusals in the beginning because people don't, what Social Security says you need to get in, they don't actually help you get it in or help the providers get you, the records. So if your records don't show up, no one tells you and says, hey, you need to get these records, unless they're a really exceptional worker at the office where they make the decisions about Social Security. So you need, again, it's helpful to have someone who can help you do that. And if, I can, I know of different people around the state who can kind of be a resource for that if people want to let me know, and maybe I'll put together. I mean, the ARCs are one good place to start because they can either, sometimes they have someone who works with people on applications, or they can refer to someone. And if you get an attorney to help you, they only get paid if they get benefits. So to get you the benefits, and it comes out of the, usually out of any back benefits you're owed. So there's no fee for that up front. So that's what usually happens. But it's again, one of those processes that's pretty long and can be rather arduous if you have a disability that's kind of on the borderline, that's not, totally recognized. But for people who have, moderate to severe intellectual and other kinds of disabilities, usually they're, there's they don't usually have much of a problem. And there's some disabilities that are just considered, you're automatically eligible, like Down syndrome. If you have Down syndrome, it's an automatic yes, basically. Unless you have assets that are over. You have to watch that with SSI. There's a $2,000 level asset in the person's name, the adult who's applying. It's complicated.
It's complicated, and I think it also, there's a role for advocacy here. So this is something that we'll be, as part of our leadership role is to be looking at not just what are we doing for our individuals, but also our advocacy for policies, programs, and budgets and voting. So I won't go further into that, but it's, as we're looking at potential cuts to Medicaid or moving to block funding and things like that, we need to be thoughtful about the impact on programs to support individuals with disabilities. So, Mike, looks like you had something you wanted to say.
I guess, another resource, like you mentioned, is My DDI. I mean, one thing we are very good at is connecting people to these types of services that others are looking for. And we hear from a lot of physicians. We hear from, folks across many disciplines who say, hey, I know this person, or I have this patient who has a child with a disability, or they, a patient with a disability, and they're looking for this. And that, those are the calls that we get probably every day. So, of course, keep us in mind, and we serve the entire state. But one thing I did want to mention really quick, as we're talking about these different services, and it's something that I know the direction we've been kind of going into lately is looking at things such as Uber or Lyft. How can we harness that service for folks with disabilities? And then on the other side, how can we perhaps train or educate folks with disabilities on safely using those types of services? So as far as transportation, I know, like Uber and Lyft, the two big ones, that those have been getting a lot more play with folks with disabilities, especially families.
Oh, yeah. Get a ride when you need one.
Mm-hmm.
Well, maybe we want to kind of wrap up, but I hope we touched on some of
Jen, I just had one more thing. Christine and a number of her colleagues here at Wayne Medical School developed a poster that they were unable to go and present at the Academy for Communication in Healthcare. So I presented for them yesterday evening, and I had a number of people that came up to me and asked whether the poster was related to the projects with LEND. So just wanted to let you know that people are recognizing that Michigan does have a LEND program. Specifically, a gentleman from Miami, Jeffrey, I think is the name, who said to tell you and Sharon, congratulations on a good poster.
Oh, thank you. Thanks for that feedback. That's great. Okay. Any other comments, or shall we wrap up a couple minutes early? Well, I hope this was useful to sort of to think about some different ages and some different conditions, lots of common themes, and lots of things for us to be thinking about, and probably raised more questions than gave you answers. Am I right about that? Probably. Okay. Anything else? Any final comments, or shall we close with that?
No one has their hand up right now.
Okay, well, thank you all for participating. I'm very, very, very pleased. And a nice thing about this is how much I think I know I do, and I'm guessing that other faculty members learn as well, as I hope it's good learning for you. So thanks a lot.
And you all get a break next week. So now our next Zoom session will be Tuesday, October 24th, Dr. Milberger. So enjoy the week off next week. Well, off from Zoom sessions at least. I'll send the registration link for that in the next few days, and also look for an evaluation of tonight's session shortly. Thank you, everybody.
Thanks a lot.